Thank you, Andrea, for this very kind introduction. I'm very happy to be the first speaker in the course, and the room is quite full. So let's start with PI-RADS, PI-RADS version 2. I do not have any conflict of interest. And actually what happened in 2011 is that a group of urologists and radiologists, well, they realized that we needed a standardization for prostate MRI. MRI at that time for prostate was at a very poor stage, and that was actually the beginning of what happened afterwards. We need to speak the same language. My language is Nederlands, is Dutch. En als ik Nederlands praat, kunt u mij niet verstaan. When I speak Dutch, you can't understand me. You may have your own score for prostate, but if we want to communicate in Chinese, in Italian or in Russian, this all means MRI, we need to speak one language, and that's PI-RADS. So what happened is that shortly after that, the ESUR group published a paper. It's now one of the best cited papers in European radiology, and that was PI-RADS version 1. PI-RADS version 1 provided guidelines for magnetic resonance imaging and prostate cancer. It described clinical indications, the minimal and optimal imaging acquisition protocol, and it was introducing more or less of a structured reporting system on a 5-point score. However, there were of course limitations. And of course, another thing is that with prostate MR, everything evolved in a very rapid pace. And actually, we wanted to make it keep it simple, stupid, so that everybody could use PI-RADS version 2. And of course, we wanted to have one single international standard, not a European standard, no, a world standard. And for that reason, the American College of Radiology, the ADMITEC Foundation, and the ESUR decided to collaborate. And finally, in last year, we published a paper in European Urology with PI-RADS version 2, so an updated version. And this was awarded as the best scientific paper in European urology, so that means that urologists also realized that this is something special, and they want to know it. They want to know whether a lesion is a PI-RADS 1, 2, 3, or 4. So, both PI-RADS scores were based on evidence and expert consensus opinion. They discussed the minimum requirements for acquisition. They had a similar 5-point final scoring for T2 and diffusion. They had a lesion given an overall score based on all the multiparametric imaging, so all the sequences of being called a clinically significant cancer. Of course, there were caveats. We modified the sector map, but that's not that important. So, the acquisition protocol, it should be good, cheap and fast. And the acquisition protocol is at least in 2 planes, a T2-weighted image in a good quality, preferably in 3 planes. Diffusion, using 3 values, preferably 50 and an intermediate and a higher one, and based on that you can calculate a B1400 map, or you can acquire it, but you must do it, you must use a B1400 or higher. And that's new from version 1 to version 2. And with DCE, the time resolution should not be more than 15 seconds. Okay, now PI-RADS version 2 focused on lesion detection and characterization. The interpretation and reporting was a little bit modified. It was in better description, and there was an atlas. Now, what is a clinically significant cancer? In the afternoon speech, I will also focus on it. If you ask a pathologist, it's different from a urologist, from a radiologist, and we can have that discussion the entire morning. What is clinically significant? So we tried to make a compromise. We said, well, it's the Gleason score, which is equal or more than 7, including a 3+4 with a prominent Gleason 4 components, but not predominant. So now the question is, what is prominent and what not predominant? We do not know yet, but if you have a minor 4 component which you do not see at the MRI, we had the feeling that that was not a clinically significant cancer. The volume should not exceed more than 0.5 cc, and of course, if you have extra prostatic extension clearly visible on the MRI, it is a clinically significant cancer. Now you have the assessment categories. 1 is a very low chance of having a clinically significant cancer. A low is a 2, a do not know is a 3, a 4 is high, and a 5 is very high. And I will give some data later in my presentation. Now in PI-RADS version 2, the highest B value was 1000, and we increased that to B 1400. And as you can see, this is a dark hole, an ADC with a low value restriction, nicely shown bright on the B 1400. And if you go to the B 2000, it's even better. So high B value imaging is a must in PI-RADS version 2. Forget about the pharmacokinetic mapping, just look at the early enhancement. If a focal area which matches an abnormality at the other imaging sequences is enhancing earlier than the rest, it is called a plus. If it's not, it's a minus. So this is different. In PI-RADS version 1 it was a 5-point score, now it is a simple yes or no. That means that we are a little bit devaluating the use of DCE. Forget about spectroscopy, it's nice, it's very good, and if you can do it in the transition zone, for equivocal tumors, it may obviate the use of biopsy, but it's not being used in PI-RADS version 2. Now we have a different way in looking at images. It was actually not described in version 1 how to come to a final diagnosis, but in PI-RADS version 2, we had in the diffusion-weighted sequences is a predominant sequence in the peripheral zone. So it dominates the other sequences. In the transition zone, it is the T2 which dominates. DCE plays a minor role, and again, we try to make it simple, keep it simple and stupid. So this is all in the publication of European Urology. You can download it for free, it's an open access. This is the scoring of the peripheral zone on T2 weighted imaging. And you can see that if you have a circumscribed, homogeneous, moderately hypointensive focus mask confined to the prostate, which does not exceed 1.5 centimeters, in its greatest dimension, it's a 4. And I will show you a few examples. This is a uniformly hyperintense signal intensity of the peripheral zone. So the peripheral zone is normal. However, you see erased charcoal in the transition zone, so this is a TZ tumor. But the peripheral zone is absolutely normal. You usually see some strands of fibrosis. This is normal anatomy. This is a little bit more difficult, this area over here. This is slightly hypointense, not really sharp. This is edema and inflammation due to prostatitis. And this is the normal peripheral zone. This is a scar tissue, it's triangular, it's sharp, it's not really a mass, but it's fibrosis. Now here it becomes a little bit more clear that we have a lesion, and this is called a 4 at T2. And finally, if you have something like this, it is of course a 5. You can see actually some bulging over here, a broad contact with the surface, which may indicate minimal extracapsular disease. And again, if you see obliteration of the rectoprostatic angle, this is a 5. And this then is also a PI-RADS 5. Obliteration of the normal rectoprostatic angle. Again, there is a lesion over here in the transition zone. So I will now focus on the most important sequence of the transition zone, the T2. Have a good quality T2, not only for the extracapsular extension, but also for the transition zone. This is a difficult area, especially a 2 from a 3. If it's 4, if it's a non-circumscribed, homogeneous, moderately hypointense and great, not too great lesion, it's easy. And this is what Joe Bush calls organized chaos. This is what you see in BPH. Nodules which are bright, which are dark, which are intermediate, but there is structure in the nodule, and usually the lesion has a capsule or a pseudocapsule. This again also is organized chaos. Here it becomes a little bit more difficult, and this is the most difficult area. Is this a PI-RADS 2 or a PI-RADS 3? Well, it's what you should do, look at the other planes, how it looks. So if it's sharp on the other planes, it's 2. If it's unsharp in all the planes, you could call it a 3 or perhaps a 4. This is a clear disruption of organized chaos by what I call erased charcoal. When you have a charcoal drawing and you put your finger over it, it gets fuzzy. It is intermediate signal intensity without internal structure. And it doesn't really behave well. It is not respecting its borders. So this is a PI-RADS 5 on T2, so the final score also is a 5. You have some difficult lesions as well. Sometimes you have a lenticular shaped lesion like this, typically of an anterior tumor. It exceeds 1.5 centimeters, so it's a 5. Lenticular shape, and you can see that it's a little bit protruding, pushing backwards the normal organized chaos of the transition zone. Now in DWI it's easy. This is no abnormality. This is the ADC map, this is the B1400. You see, however, a lesion over here, which is the normal ejaculatory duct. So in most patients you see centrally from the top to the mid-prostate running a dark area in the midline on the ADC, bright on B1400, not a tumor. This is of course something else. You see a lesion over here which is dark and which is very bright. The ADC value is 500, so this certainly is a PI-RADS 4, a significant lesion. When the lesion is big, when it exceeds 1.5 centimeters, it is a 5, and you can see that there is also a lesion over here. But again, in the transition zone, T2 is dominant. This could be a BPH nodule. But this certainly in the peripheral zone is a cancer, a PI-RADS 5. Now with contrast it's easy. You see a lesion on the other sequences. You see on the ADC map a low area which corresponds with early enhancement. You can see the same over here. So you could call this a plus. And now this is the most important slide. It's just like a game board. You have a lesion either in the peripheral zone or in the transition zone. That's the most important decision you have to make and the most difficult decision. If it's in the peripheral zone, diffusion is dominant, except when you have a score of 3. If you have it in the transition zone, the T2 is a dominant sequence. Now let's have a look at this case. This is a difficult case. This is the 2 planes on the T2. On the ADC you hardly see anything, but you see perhaps something of a brightness over there. And the ADC value was 950. So on the T2 you would call this, first of all, localized lesion. The lesion is localized in the peripheral zone. So it's over here. This is the scheme, the sector scheme we use. So peripheral zone lesion. For the T2, the score is, well, it's not a real focal area. It may be prostatitis, so we call this a 2. Diffuse, mild, hyperintense, usually indistinct margin. And we call this a 3 at diffusion-weighted imaging. It's not a yes, it's not a no. And now contrast is important, because if it is not enhancing, it's a PI-RADS 3, and if there is enhancement, it's a PI-RADS 4. You can see focal early enhancement. This is the K-trans, but this is a focal early enhancement area here at the Cineloop, and it corresponds with the other lesion. You can see the curve actually going up, going down with washout, so this definitely is a significant cancer, so we upgraded it to a PI-RADS 4. And actually this appeared to be a Gleason 4+3 lesion at biopsy. Now, what do we know about the value of PI-RADS? Of course, your own Likert score may be slightly better than the PI-RADS because it's something new you have to learn. This is a nice meta-analysis. PI-RADS version 1, reasonably good sensitivity and specificity. You can see that PI-RADS version 2 increases to 82. This has been confirmed by Park and radiology. Sensitivity and specificity quite good. Inter-reader agreement in his group was 0.80. So I think they were all experts, and multivariate analysis showed that the PI-RADS version category, when it is 4 or more, is the only significant parameter for clinically significant prostate cancer. Now this is the most recent paper of Woe et al. You can see that the PI-RADS version 1 performs well, but that especially here that the sensitivity of PI-RADS version 2 is better, with an equally reasonably good specificity. So this is what we know about PI-RADS version 2 at this moment. What are the challenges in the future for PI-RADS version 2? This is my own perspective. It's not being supported yet by the PI-RADS committee in the US or the ESUR, but there are some challenges. You need to adapt to a new system, so you need to train. To reduce the inter-observer variability. Also the image quality needs to be good, but the inter-observer variability, you can see that in some cases is quite good. And this was a statement of Andy Rosenkrantz. He said the inappropriate use of PI-RADS version 2 by new users who have not sufficient training may be damaging to clinical care and may be screwing up the PI-RADS evaluation to urologists. They need to rely on a good diagnosis, so you need to know and you need to perform well. There is an overlap of BPH with the PI-RADS version, with the transition zone. There's overlap of BPH and cancer. They both may show a low ADC value, restriction, very dense tissue, hypercellularity. So I think in the future we should explore the role of higher B values. In the first part of the ADC curve, we are looking at the vascular phase. In the part which we currently are looking at the water which is in between the cells. So high cell density, BPH or cancer has a restriction, less motion of water molecules, but actually I think most interestingly, if you go to a high B value image and you can calculate the images, you may see something about the exchange of the water molecules along the cellular membrane, which may be different from BPH and cancer. So there may be a role for BPH. For example, if you look at this lesion, obviously a low ADC, bright on B1400, even more brighter on B2000, and the only area which is bright is this area, and this appeared to be a Gleason 4+3 cancer. By the way, here you can see the erased charcoal sign. There's also a subjectivity, so we need to quantify in the future diffusion-weighted imaging. And my advice to you is, explore and evaluate in your institution which ADC value is the threshold between cancer and no cancer. It may vary a bit from system to system. With our system, Siemens, Skyra and Prisma, it's about 900 to 850. So if it's up above 1000, it's nothing. If it's below 850, it's cancer. But you have to find that yourself based on the feedback you get from the multidisciplinary teams. DCE is a secondary sequence, so it only uses an upgrade, but be aware that the upgrade also may increase the number of false positives. That means it may indicate an insignificant cancer instead of a significant cancer. Now the question is, should we use DCE in the future? It's still not being answered. I think for screening the answer is no, but for a clinical MRI still the answer is yes. If you are a non-expert, contrast may help you. I'm confident that if you are an expert, you don't need contrast that much. So try to become an expert, and you can obviate the use of contrast. This is the screening protocol, the abbreviated protocol without contrast, and the full protocol of Christiane Kuhl. She published this recently in Radiology, and you can see that there is an equal performance in a negative predictive value. There's only the specificity is slightly lower using the full protocol. She was even better. So the message is that for screening, probably contrast is not needed. Now, size. We are bad at size when it's a Gleason 3 lesion. So why did we take 1.5 millimeters? Should we go down? In the past, I would call this lesion with an ADC of 500, and very bright, I would call this a 5. And this is a Gleason 10 lesion. But now I have to call this a 4. So there's more than size alone. Still, we have to figure what we should do in the future. At this moment, still the rule is 1.5 centimeters. It's stated in the PI-RADS version 2 that you should look at the images without the clinical scenario. I think that's not what I'm doing in my clinic. I'm looking at the clinical data as well. That's very important. I'm looking at a high suspicion lesion or a low suspicion lesion. If the PSA density is high, the PSA density is PSA divided by the volume. So if the PSA density is above 0.15, I'm getting a little bit uncomfortable if I don't see a tumor. You can do the same with the free total PSA ratio. When there is a genetic profile, a positive diarrhea, and also the age of the patient is important. Should you do a biopsy on an 85-year-old man in a PI-RADS 3? The answer probably is no. Should you do it in a patient who is 50 years of age? The answer is probably yes. So it has been shown by Vendrick and all that if you have a lesion PI-RADS 3 which has an PSA density above 0.12, then the chance that it is a significant cancer increases. When it's lower, the chance is extremely low. So this is one of the things which you may include into your interpretation. Also take into account the population you're looking at. If you look at the biopsy-naive patients, so actually it's a screening population, what is the biggest harm you can do to such a man? Diagnose an insignificant cancer. So we should do harm reduction. Does that mean that we have to look at with high sensitivity reading or with high specificity reading? Sorry, this should be, we should look this with high specificity reading. I did this on breakfast this morning, so this is wrong. So you should really, if you are in doubt, you should say to a patient with a biopsy-naive patient, you should say no. If you have, however, a patient who has a high clinical suspicion and a negative trust, you should use high sensitivity reading. That means that if you're in doubt, you should say yes, because the likelihood that there is a cancer is there and the urologist wants to find it. So again, harm reduction in biopsy-naive patients, high specificity reading, and just increasing your sensitivity when there is a negative trust biopsy. There are no guidelines or recommendations for follow-up or biopsy. One should we do biopsy or one shouldn't we? And in PI-RADS version 3, we will have a paper, and Anwar has, with some other co-authors, a very nice paper in progress. It should be based not only on MRI, it should be a combination of a talk between a urologist and a radiologist. We have part of the puzzle, they have the clinical history, PSA kinetics, age, family history, diarrhea, etc., etc. This is important. Together you make the decision whether you should do a biopsy or not. What do I recommend based on my own experience, but you may just use a slightly different protocol. In 1, no follow-up. In 2, follow-up of MP-MRI if the PSA increases. So send the patient home, go home, be happy you don't have a cancer, but I want to have your PSA within 1 year. And if it's stable, that's good. Then he can go home without an MRI. If it increases, you could consider to do an MRI. If there is a low PSA density in the PI-RADS 3, do follow-up MRI within a year. If there's a high PSA density, do an MRI biopsy. But again, this also depends on other factors. And you can see that the yield in literature is about 20%. If it's a 4 or a 5, do an MR-guided biopsy or an MR-targeted biopsy. And it depends on the size and the shape of a lesion, whether you should in-bore or whether you should use truss MRI fusion. And you can see that it depends on the publication, what the yield is. In PI-RADS 4, it's in between 40 and 80%. And in 5, usually you should find a cancer. Again, there is no 100% dominance. Use your experience. Use also what you have learned, what your feeling is. Prostate imaging is not only cognitive, but it's also a feeling. This is, I would like to show you the value of diffusion-weighted imaging in a transition zone. When I read this prostate, I would say nothing is wrong. His PSA density is 4, PSA is 4, PSA density 0.5. But if I look at the ADC, the ADC is 500, it's very bright at the B2000, and then I'm looking at this area and say, hey, isn't this erased charcoal? I'm not sure. Now I'm over-projecting the B5000, and we did a targeted biopsy in this lesion at this spot, and we found that this was a significant cancer, a Gleason 3+4. So that means that diffusion-weighted imaging can help in a transition zone. On the other hand, if you have a patient who has had a thrust biopsy, and you can see here, this patient, he has a PSA of 7, PSA density 0.13, negative thrust biopsy. You can see a black and a white area here, just at the rim, but it's not really focal. It's over here, and actually, you should call this a PI-RADS 4. So that means high suspicion of cancer. Actually, this is what we have biopsied many, many times, and most of the times what came back from the biopsy was scar tissue with inflammation. So this is inflammation due to the previous thrust biopsies. And what also is our experience is if you look at the biopsy so when you do the biopsy in bore, you make repeat the image, it's usually very difficult to find a lesion. So in this case, it's not only diffusion in a transition zone. So with this, I've come to the end of my presentation. I gave you a short view of PI-RADS version 2. I gave you some impressions of where we are heading to. In this afternoon, I will just zoom a little bit more on the early detection, what's important, what's not important, and how we should do that. With this, I've come to the end of my presentation. My message is, if you are starting prostate MRI, go to courses. Learn, learn, learn. We have to teach, teach, teach. That's the most important thing. See as many prostates as you do. When you've seen more than 3,000 prostates, the world is different than when you've seen 500. And you know that some guys in the audience have seen more than 10,000. And when they look at the images, they just see the tumor at the spot. But still, you can miss tumors. What we do in our institution is every PI-RADS 2 and 3, we double read. That's important because on a Friday afternoon you may miss a tumor. Use PI-RADS. Go for the prostate. It is a bright future, but we should do it well, otherwise the urologists will not believe us. Thank you very much.